discussion, but I'll start off with the case. I would request Dr. Janak Desai sir, Janak sir, Ganesh Bakshi, Vivek Venkatramani, Amlesh sir, Amlesh sir, haven't seen, and Anant Sivaram Krishna. Ravi, Amlesh sir is not there? Okay, he'll join. Okay, so I've got a panel discussion rather than a case-based discussion, but I'll start off with a case. So now I've got everyone on the panel. Okay, so I will start off with probably the disclaimer, which is the most important one. It isn't about that I know everything about this. Whatever I know about it is what I learned in the last 2 weeks since I came to know that I was doing a panel discussion on this. Okay, so it's more about sharing what we do as good practices and probably trying to abandon some of our bad practices. Typical scenario, 60-year-old gentleman who has got intermediate risk prostate cancer. MRI scan says that there is some element of prostate cancer, pyrad 3, neither here nor there, and PSMA is negative. So he is intermediate risk because of the Gleason score. PSA is around 7. Okay. Are these two important, Ganesh? In determining what you would do and with respect to what you would counsel the patient about? Preoperative IPSS score. Do you think that's important?
IPSS score, it's high here. So
yeah, it's high.
That may not be so important. But
okay. Shim score?
Shim score we should document preoperatively.
Okay. The reason why I was asking about the IPSS score is when it comes to it, the patient does have significant obstructive urinary tract symptoms, means that probably he has got a larger prostate. Doesn't need to be always, but the bladder is used to working against a lot of resistance. And you suddenly remove the resistance, so the continence might take longer. That's what I was trying to comment.
True.
Okay.
I mean, these patients may have a slightly delayed return to continence.
Okay. So what would you tell him? You do a very good nerve sparing operation and you have done every step that you want to. What is the risk of incontinence in a 60-year-old? At 3 months and 6 months. What would you quote?
So at bilateral nerve sparing,
everything what you can do, you have done, and then you say at 3 months, what would be your incontinence risk? What would be the 6 months incontinence risk?
3 months, it can still be.
Give me a number.
At 6 months, it is easier because 3 months, none of the patients would be focused. They would say, I am not so continent. They are busy in their other troubles.
Okay, 6 months.
So 6 months, it should be bilateral nerve sparing, something like 70% or 65%.
Okay, 65%. No pad usage or one pad usage?
6 months usually between no and one, because some people still complain few drops can leak, which is in the definition of continence actually.
Vivek, in your part of Mumbai, are the continence rates any better? At 6 months, what is the number you would quote? A 60-year-old, you have done everything you can.
So if I've done everything, if I've done everything I can, I would say about 80%.
80%.
Yeah.
Anant, would you differ, or Chennai, they are all born continent?
I'll agree with
okay, 80% is what you would say at 6 months. Janak sir, agree with that? Okay. And what do we agree as definition of continence? Same, saying that either no pad or one pad usage.
Yeah, ideally it would be no pad only, but I think for our benefit it is one pad nowadays.
Okay.
Which is easy to explain to the patient, but I would still in my clinic talk about mostly coming to no leakage.
No leakage. So 65 and 80%, that's one. And ED, you have done everything. He has got a good Shim score. Vivek, what would be the...
Yeah. So ED, I'm very careful and cautious, like the last panel also. Yeah. So I tell them almost 30 to 40% will, whatever we do, they're not going to recover.
Okay.
So, and even if they do recover, it's never going to be as good as what it was before.
Okay.
And it may take up to a year or two, even sometimes longer than that. Okay. And in that time, we will be able to help them out with some, medication or something like that.
Okay, I haven't got any number on her. So at 6 months, erectile dysfunction, what is the risk?
I would say 80% risk of, yeah.
Risk of ED,
ED,
at
yeah.
6 months is
Very
80%.
few minority would be actually having good enough
Okay.
erection.
And what's your definition of ED in this patient?
Satisfactory enough for penetration.
Okay. And time duration of recovery, continence and ED same? Or you think continence is early by 1 year, if it doesn't improve long term?
Usually that's the case.
Okay, 1 year, if it doesn't, then you are thinking, what should I do? ED, it will get better up to 2 years. We all agree?
So
Yeah.
I'd like to make a point here. I've always found that the Indian men kind of overestimate their ability, right? Whenever
All
you ask
men, I
them,
think.
Huh?
All men, probably.
all men, all men. So in fact, if you ask their spouses to do the same shim score, the score is always lower,
Okay.
right? We've done a couple of studies on this in the sense, just an informal thing. Always the shim score by the spouses is lower than when the men do the shim score.
So probably we
Right?
should have this aspirational shim score and realistic shim score.
I think this is a learning point. We should have a spouse.
So, those guys, the expectations also is amazing. I'll give you another example. Somebody who's totally not had sex for the last 5 years expects to have sex after robotic prostatectomy.
And one thing I just wanted to clarify here, quite often they tend to think that the cancer is what is causing the erectile dysfunction, and we do need to put in that statement saying that cancer isn't the reason. They seem to be because they say that you have treated the cancer, how come I'm still having the sexual dysfunction? Okay, so just to get the realistic numbers from a randomized control trial, we can always say that we are much better surgeon than any of the surgeons in England, but these are the numbers. 750 radical prostatectomies compared to radiotherapy and active surveillance. Protect trial, just for the initial, I thought I will just give you the number. And what you see is continence. When you look at these, at 1 year, almost 33% of the people are using one pad or more than one pad. 33%. A third of the people are still using one pad or more than one pad. Okay? Compared to almost much less with radiotherapy on them. And surprisingly, if they don't improve, it does seem to improve up to 2 years. And if it doesn't improve by 2 years, you can say that they are not going to improve. And the last one is at 6 years, almost 20 to 25% of the patients are still using one pad a day. Okay? And this is from a randomized control trial, and they were trying to look at the difference. So this is what is there, and 750 is a large number, we can't ignore. So urinary incontinence is a significant problem in patients who have undergone a radical prostatectomy. Negative thing element of this is open prostatectomy. These were all open. Ganesh, you have done both. Which one do you think is better with respect to continence, open or robotic?
I think it is the same.
Okay.
If you can do bladder neck sparing in both, it's the same.
Same.
We had compared our TMS data with both open and robotic. Not only in that, even the lymph nodes were the same.
I felt that open, the continence recovery was quicker, just because you didn't see anything of the sphincteric complex. So you always ran away from it, and the continence was quicker, at least from when I was doing my open compared to robotic.
We didn't record that time.
Sorry? Yeah.
We didn't record that time.
The last thing I wanted to know, the sexual dysfunction, according to the PROTECT trial, if you see, almost 50% of the patients do not end up having any sexual activity, even long term, up to 6 years, around 50% of the patients. Okay? So this is from a well enough conducted randomized control trial. 25% of the patients have of urinary incontinence of some sort, and around 50% almost never have sexual activity. Men reporting sexual, if you see, up to 50%. Okay? And what I was coming at was robotic, is it any better? This is comparison of robotic to open. And if you see there, 85%. So at least in this trial, they were better. So this was no pad usage at 6 months, 85 and 84%. But long term, almost I haven't seen, unless there were individual case series, it never reaches 100%. Why is that so? Vivek, you are shaking your head vigorously. We keep on saying that they used it. 100% of my patients are continent. How come in randomized control trial we never get 100%?
So I think whatever has to recover generally recovers more quickly. And then once you have that plateau at around a year, it's not going to recover beyond
No, what
that.
I'm saying is, what is the long term? You have done probably 300 or 400 prostate. You think that you have seen enough of anatomical variation. How come we are not getting to 100%? Robotic assisted radical prostatectomy is 24 months, is 91% no pad. And if you include both, we are coming up to 97. How come it's not reaching 100%? Amle sir?
Yes. Basically it depends upon the anatomy. And we know that there is a good percentage of patients of cancer prostate where the disease would be there in the apical area. And we would definitely not like to leave cancer when we are going ahead with a cancer operation. And in that situation, if there is a little bit of damage to the sphincter, that is something acceptable, and some degree of incontinence is acceptable. Regarding the previous issue of open versus robotic, in the era of open, I think the incontinence rates were higher. With the robotic, the incontinence rates have come down, and now after watching robotic, if you go back to open surgery, your results in open surgery would be as good as robotic, because with the magnified view of the robot, we have started understanding the anatomy of the apex much better. The other thing that has come up in the recent years is the understanding of the sphincteric anatomy by MRI studies, which were not there earlier. If you read the earlier literature, the understanding of the sphincter mechanism was not as good as it is now. And at the present time, the open and robotic surgeons will have equal continence rates. But if we compare the historic open with robotic now, the continence rates now should be better compared to the open surgical rates at that time.
Okay. So technique is more important than technology. Janak sir, agree?
Yeah, so there was a study from Mayo Clinic in which they studied the length of the sphincter.
That's what I'm coming to, sir.
Yeah, okay.
Don't
So
steal
if
my
the-
thunder.
if that is big enough, the continence is,
Yes.
and a second study from Hopkins in which when you do a nerve sparing is not only for erectile
continence
dysfunction, it
elements.
is also for continence. A
Yes.
10% contribution comes because of those nerves, not only the sphincter. So we have to keep these two things in mind.
So objective will be to spare whatever you can and preserve whatever you can. Okay. So continence preservation, non-modifiable factors, age. When do you start counseling? A 75-year-old, is he older than a 70? Numerically, yes. Where is the cutoff mark? You say, I do not want to do a radical prostatectomy on him. Ganesh, any number? Wherein you say, okay, the significance of incontinence is higher.
Age-wise?
Yeah, age-wise.
75 onwards you can gauge, but I don't refuse radical prostatectomy. It depends on the overall ECOG and the fitness and the life expectancy.
So would you say that a 65-year-old would regain continence early compared to a 75-year-old? Or the risk of long-term incontinence is
This
more
I have
or less-
seen in practice. Elderly patients have a delayed reach to continence.
Okay, and size of prostate, any? Okay, it said that there is no benchmark to say that 40 or 50, but they say the larger the prostate, the more is the disruption to the anatomy, because of which it takes longer. Okay, membranous.
Sanjay, can I make
Yes,
a
sir.
small comment regarding the age? The MSKCC, the website is open to everybody. And what is the longevity with surgery? What is the longevity irrespective of the disease? Everything is there.
Yes, sir.
So, and there are factors
Yes,
like the age, the presence of diabetes, the presence of hypertension, asthma, and neurological issues, etc. Based on that, they have life tables that are available. So if a person has a 10-year life expectancy, irrespective of the age, that person is acceptable and suitable for a radical prostatectomy.
Okay, I would have said for radical treatment rather than radical prostatectomy. Okay. So membranous urethral length, that's what Janak sir was mentioning. Do we ever look at this, Vivek?
So not specifically on the MRI, I know it can be calculated, but intraoperatively we are always trying to preserve as much as
No,
we can.
you have already crossed the bridge though, once you have gone up to the intraoperative one. Okay. I started looking at it only since I've started preparing for this, and it's quite an easy one to measure. Yes, we have this vision. So it is from the apex of the prostate to the penile bulb. and every millimeter seems to matter. So I was thinking, whom would I look at? If there was somebody who was, let's say an elderly guy, 80-year-old guy who is very keen to have a radical prostatectomy, just for me to gain confidence that, okay, he doesn't also have a short membranous urethral length. If he has got 5 millimeter length, then you say, okay, you are going to leak anyway. There's no point in. So, or somebody who is a very young guy, I want to be sure that he doesn't have any anatomical deficit. That's where I've started looking at it. And what you see is, range is huge, from 5 millimeters up to 34 millimeters. And every millimeter matters. And as you can see here, the longer the membranous urethral sphincter area, the better is the earlier chance of continence, and the long-term chance of continence are also better.
So I have seen is that, you know, those obese guys who are short, so they have a more difficult, you know, return to continence. Yes. Do you think that could be related to the membranous?
Obesity actually itself is an independent predictor of delayed continence. All those things probably matter, but you can measure obesity much more easily compared to any of these things. So they measured obesity and said, the higher the BMI, the longer it takes for the continence to recur. Okay, so modifiable is obesity. So you can ask them to lose a kilo, because that's what you ask them to 5 kilo, they'll come with 1 gram decrease. Metabolic comorbidities, diabetes or any of those things are there, the better control, and pre-existing LUTs is a predictor of delayed regaining of the continence.
Can I make a point?
Yes, sir.
When we have a short sphincter, we were taught by Pat Walsh that you have to hitch the DVC to the pubic bone, and now it's given up. But I think, you know, I've just done 100 robotic prostates. I'm a kindergarten kid. But each time when you hitch it, the patient probably has a better control on continence than leaving the sphincter hanging in the air. Okay. The theory is that you need the valve to have a connection on both the sides.
Yes.
So does that help? That is the question.
I did not want to go into the technical tips of improving the continence. That's why I haven't gone into that element, sir. Yes. So obesity we can try to decrease, but we can try. It won't come down. Metabolic coma we can't do, but we can do something about the lower preoperative maximum closure pressure, which is related, and that's where the pelvic floor exercises come in. Rehabilitation, do any of you do? Okay, everybody vigorously say. I'm going to put you on the spot and say, Anand, what would you do? Just tell me what would you do in prehab.
So just before we go into that, I think when we're assessing a patient for prostatectomy, a digital rectal examination, their ability to clasp your finger tightly with their rectal muscles, I think the sphincteric muscle is so important to counsel the patient. You know, at the first instance when they come into the outpatient department, I've counseled patients against prostatectomy based on their...
I would agree with that. So that is, once you know that you are going to do a radical prostatectomy, instructions wise, what do you give them?
So there are two things we do. Number one is when the patients come in, there's an in-house physiotherapist that starts them with Kegels exercises.
Okay.
And then
all
another
the
thing that
Kegels
we do is...
All the Kegels exercises?
All of them, about 6 of them we teach.
All of them?
All of them we do it.
Does anyone else do differently? Okay.
And there's one other thing
then
we do as well.
Sorry to put you. Second one, how many times?
Now, pre-operatively, I don't stress on the number of times. It could be anything between 100 to any number that they want.
Then the third one, I'm going to say, for how long a duration? The reason why I'm just going to try to give answers, so that's why I'm just
from the time they've had the biopsy and I've counseled them for a radical prostatectomy till the time we do the surgery. It's about 3-4 weeks.
Do you believe that it makes a difference? So let's say that if somebody comes to you, has had a biopsy done elsewhere, you are booked in for surgery next week, yes? Are you worried that that guy is going to leak more compared to somebody who has gone through your system and you have done the prehabilitation?
I'm sure it can't hurt them to do the Kegels exercises.
So you're doing it because it doesn't do them any damage.
And also their ability to, the muscle memory is pretty good when they do it post-operatively.
They use
I think there is a learning also, Sanjay. Means they do pre-operatively, they learn that exercise well, and then they know what to do post-op. Because many patients who just land in and get operated, and if at all sometimes it is missed, they take a long time to learn this exercise later. in a correct manner.
I agree with that. So these are the 4 keywords. Sorry to cut you short, Anand. So majority of us do that third one, which is we give a bit of an idea about it and expect the patient to know. The last one is the PFMT. Difference between that one and that one is somebody just saying Google Kegel exercises and start doing it, compared to the second one, you say do the Kegel exercises, this is what you mean, and then you give them an instruction leaflet, and generally it includes a biofeedback. I'll tell you what that means. So we are supposed to be, each of them has got a difference. Prehabilitation is better compared to just rehabilitation. PFMT is better compared to PFME. Okay? There are almost about 20 different randomized control trials doing each of this. That's the reason, and each of them have got some number of patients. And the biofeedback, do any of you do? You said you would do the digital rectal examination.
So we also have a biofeedback. There's a company that does it called Jogo. I'm sure you've heard of them. So that company has a biofeedback mechanism where they kind of give them the amplitude of contractions, the power of the muscle, and so on. If done preoperatively, you can compare it with your postoperative outcomes as well.
Okay. So
right?
each
So
of them added on. So prehabilitation is better compared to rehabilitation. PFMT is better compared to PFME, and biofeedback one is much better compared to any of the above ones. So we always are, the easiest one, the biofeedback is this, any visual, auditory or tactile strategies to make them know that they are doing the right way. So as Ananta said, having a finger up the bum and say, yes, you are squeezing the right muscle is good enough. Okay. The second one, stopping the urine, that's again a biofeedback, but don't train them doing it. Yes. You can ask them to do it one and say, yes, that's what you are contracting well enough. That's a visual cue for them to say it. But the best one is the perineal ultrasound scan that will give you a proper tone whether they are measuring or not. Okay. This one is what I was trying to get at. So it's not the best trial, but it answered all the questions that I wanted to. So they assessed based on a questionnaire, PAT test, and the transrectal ultrasound scan based assessment of the perineal flow, and had around 50 patients in each group. Okay? And this is what is the difference. So the routine one, which is what we do, 30-minute session, 2 sessions before the operation. They had 3 sessions. They should be doing 3 sets of 10 each. So that will be 30 exercises. Compared to the intervention arm, again, I used to not do this slow twitch and the fast twitch. We are supposed to do both. Okay? So 10 seconds of the slow twitch one, 1 second each of the fast twitch one, and then we do overall 120 of them in a day. Okay? And this one is 30. And what you see is quite a bit of it. This one is, if there was only one learning point, you need to know this sentence usage. How do you make somebody do pelvic floor exercises? Is that sentence. Stop the urine flow and shorten the penis while continuing to breathe. That's a sentence we are supposed to be using. They have tried different sentences. They say that's the one that gives the best instruction. If you think shortening the penis is a bit wrong on a man, you can say pull the penis towards the base of the penis. So pull your penis into your abdomen. That's what we are supposed to say.
You have to add not with your hand though.
Yes. Or someone else's hand. Okay. So that is the instruction that we are supposed, and it does make a difference. That's why I put it in an inverted comma there. I used to always say, stop the urine flow or stop yourself from passing wind from the back passage. Passing wind from the back passage is a totally different component. It is inferior compared to this front part of the overall pelvic flow. So when you do all those things, it is better. So the intervention arm is better. And as you can say, even using the PAT test, it is better. By using the transrectal ultrasound scan, it is better. So the more you do it, the better it is. At least 4 weeks before the surgery and up to 12 weeks after surgery. And the slow twitch and the fast twitch. And the last thing, the sentence that I said. Okay? So this is what is the summary. Biofeedback, we can always say that we'll use a machine, but you can ask them to have some sort of, if they say, are you doing the exercise well enough? Stop the urine flow once and then you know that you are able to do the exercise well. And that's a sentence. Erectile function, we said that almost everybody, when you do a perineal prostatectomy, there is no hope. Robotic prostatectomy, there is a bit of a hope. But this is the message about what is the preoperative shim score and the outcomes. Anand, somebody comes to you, as you said, there is this aspirational element of erectile function, and then there is the realistic one. When would you say you would not even try doing a nerve sparing? Somebody says, I haven't had sex, I haven't had an erection in the last 6 months. Would you still offer him nerve sparing?
I think the tumor determines how close.
No, you can. These are small.
Right? If they're above 8, elderly guys, completely not having had sex for a decade or so, I wouldn't go and beat my head about her nerve sparing at all.
Okay. So, because you can't be bothered, or you think it doesn't make a difference?
So the numbers of nerve sparing that we're currently doing are pretty low. You don't get those sort of patients. It's more of higher risk patients that we're doing right now. And most of the time it's incremental nerve preservation or partial nerve preservation that we do. And I think that's a reasonable strategy even for persons who don't have any sexual function.
Is this division of erectile function preoperative good enough? Shim score 8 to 16, 17 to 21, and more than 21 is good. So the people, everybody says that they are in group 3, but quite a few of them might be in group 2, and definitely there will be some in group 1. Okay? So this is about all of them had nerve sparing surgery. Okay? So overall there were, I think, around 200 people, patients in this. All of them had nerve sparing surgery. Along with that, they had a vacuum device and Viagra. So group 1, group 2, group 3, with every measure that you can, even the ones who do not seem to have sexual function, there is some improvement when you start giving them medication and cajoling that goes with it. Okay? The group 3 is the one which has got the low shim score. Sorry, group 1 is the one that has got the low shim score. Group 3 has got the very good shim score. So this is with all the measures. That's what is the improvement. This is the PDE5 inhibitor makes a difference. PDE5 inhibitor along with the vacuum erectile device makes a difference. And almost all the time the PDE5 inhibitor is Viagra rather than the longer acting ones. Viagra full dosage, 100 milligrams in the night. So it will give them headache. Okay? So as you can see, in people who have got a very good sexual function before the operation, when you use PDE5 inhibitor along with the vacuum erectile device, they do tend to do well enough after you have done a very good nerve sparing. Which one is better? Giving something is always better. Okay? So this is on demand compared to placebo. The upper one is regular versus placebo. So giving something is good. When you say, is it on demand versus regular, they seem to be the same. Okay, so giving some PDE5 inhibitors, that's one. Second, along with a vacuum assisted device seems to be better. And either of them is better compared to nothing. There is quite a bit of a hype regarding the alprostadil injection, but there isn't that brilliant an evidence for that. So if you see there, 30 patients in the study, and they said 67% versus 20%, but overall there were 30 patients in that study.
Sanjay, just a 1 minute break. Amit has finished. He just wants to connect from the OT, and so we'll resume.
I'm done on the last slide.
Huh?
I'm done.
Okay.
Yes.
Go ahead.
Okay. Because I've got 1 minute 44 seconds. Okay. So erectile function, prehabilitation is better with this. I didn't show the evidence, but if you start off with this before the operation, it's better, even for the erectile function. PDE5 inhibitor is the mainstay. Viagra, sildenafil is the best studied drug in this. Regular or on demand doesn't make a difference. Vacuum device with PDE5 inhibitors are probably better.
Regular is still better, no?
Yeah, I think.
Yes, regular is slightly better, but not overwhelmingly. Statistically, there isn't a huge difference, but regular is slightly better, yes.
And just one more thing, ICIs you mentioned. ICIs can be offered even in non-nerve sparings.
Yes. Yes, because they will be working. Okay? So functional outcomes do matter, and we do need to, because cancer might kill them initially, but once they are a year after that, they will be bothering us for their life with the sexual function. Amlesh sir, anything to be added in the next 44 seconds?
No, thank you. You have done a very good job. You reviewed the literature very well.
Thank you. Vivek, what do you do in your practice which isn't mentioned in this?
So the AUA Urology Care Foundation, they have a booklet of how to do pelvic floor exercises. So I often just WhatsApp that to the patient so they can read it. That has this line, how to, how to contract it. That's one thing. And a lot of our patients do the yoga also. So they know this Ashwini Mudra kind of thing. So if you tell them that, that also kind of reinforces it in their mind.
So Ashwini Mudra and AUA leaflet.
Sanjay, one off patient will come and tell you my penis has shortened. So comment on that.
There is almost all of them, one of the objectives of doing the vacuum assisted device or giving them the medication is to decrease the amount of shortening. It does decrease even with the medication, but the gradation of decrease is less. Janak sir, anything to be added?
See, my feeling about this erectile dysfunction is that I have had patients, upper class, they've crossed the borders, went to the topmost surgeons in America and came back, younger guys between 50 and 60, and they are not happy with their with the erections, which means that I think whatever is published in the publications probably is, you have to take it with a pinch of salt. Most of my patients are not happy, operated by the top guys.
I'll do the other way around. Only when they have a problem, they come to you. Selection bias.
No. So each one of them for follow-up they used to come because PSA monitoring, etc. And then sir, either side, sir, wo wale mein maja nahi hai.
Thank you. Ganesh, anything to add?
So, instead of full dose Viagra, you were saying, we usually do 6 months of tadalafil 5 milligrams.
5
so
milligrams.
Again, I think that works reasonably.
The amount of evidence for that 5 milligrams and even 20 milligrams seems to be less. Though the side effects with sildenafil are more, but that's what is the one that is studied the most. So I would rather do the other way around. I would start off with 100 milligrams of sildenafil. If they can't tolerate, then go down.
Sanjay, I have a very small thing to add. I actually refer my patients to an andrologist in the hospital very routinely nowadays.
That's a better one. Thank you. Thank you all. Thanks for your time.
Thank you, Dr. Sanjay, for a wonderful discussion, I would say, and all the expert panelists. So we'll connect.